This is how you cross over from Israel to Gaza, and right now we're in no man's land. Prime Minister, do you now regret when once asked what your favourite joke was, you replied, Nick Clegg? And Deputy Prime Minister, what do you think of that?
Mr. Trump, why should you be president? What makes you fit for the role? Is it just one big ego trip?
Thank you very much.
People aren't sure they can trust what you say. You say things and then it turns out that they're not quite what you said. My name's Andy Bell and I've been a journalist for over 30 years. In this series, How Did We Get Here?, I try to provide context and background to a big story in the news. This week we are talking about coronavirus, but this time the impact on all the other services within the NHS which have been pushed to the back of the queue in order to deal with the COVID crisis. I've been speaking to Dr. Zoe Barber. She is a general surgeon at a hospital in South Wales. Since the crisis hit, her normal work's been turned upside down, and so has her home life. She tells me about the night shifts, the strain on her family, and her fears about a second, even a third wave. I began by asking her if there was a moment at the start of all this when she knew her life would change.
Yes, absolutely. I remember when we were expecting coronavirus and we weren't quite sure what was going to happen, and we'd seen the experiences of Italy and the Far East, and we thought, this is going to be big. What are we going to do about it? And that was all very theoretical until the first day that I turned up to work, when we'd cancelled all of our electives, so all of our non-emergency clinics and operating theatres. And I remember walking into hospital on that first day, everybody wearing PPE and us just having a completely different feel at work. There was no humour, there was no camaraderie. We all just looked terrified.
And what should you have been going in to do normally in normal circumstances?
So normally on a Monday morning, I'd have a clinic, so that'd be an outpatient clinic seeing patients referred with breast problems. It's normally quite a nice, slightly later start on a Monday morning, and often starts with a cup of tea. And it was completely different that Monday. I remember it vividly.
And what, did someone just come up to you and say, right, this is how it's going to work now?
Well, we'd planned it, so we'd changed our plans completely from the week before. So from the Friday before, we knew that we had to implement changes. We implemented an emergency rota that used our staff as wisely as possible to try to protect people from being exposed to the virus, but also to try to give people more time at home with their families to deal with the sort of psychological and mental health impact of what we're seeing at work. And so we went on to a completely different rota that was very different from any other rota that we've worked, that just involves 13-hour on-call shifts. So there's no normal work for us, it's just on-call.
Okay. Just in terms of the sort of work you would have been doing, give me a quick idea of the sort of work normally in your job you'd have been doing.
Yeah, absolutely. So I'd normally have outpatient clinics, seeing new patients, diagnosing them with breast cancer, talking to them about their breast cancer treatment. Fortunately, most of the time that is involved in telling people the good news that they don't have breast cancer. We then have a multidisciplinary team meeting where we discuss all of the new patients who've been referred to us. And then I would also normally be doing operations to treat people with breast problems, and that would be cancer and non-cancer problems as well.
So what happened to that when COVID happened?
Well, so this is one of the things that I think we're all worried about as all cancer surgeons, is that we have kept a bare minimum of services running. So that includes our outpatient clinics and our theatre sessions. And we are trying to diagnose and treat as many women with breast cancer as possible. But this is in a limited resource setting at the moment. And those resources are theatre space, they are surgeons, they are nurses, they are anaesthetists, because we've all been redeployed to different places. And there are some women who have breast cancer who would normally have an operation or who would normally have upfront chemotherapy, whose treatment is being drastically changed by coronavirus.
And what sort of difference is that making to them?
I can't comment, but it just must be absolutely horrendous to be in isolation or lockdown and away from your usual support network and being told by us that your cancer treatment is being changed as a result of coronavirus. Just must be awful.
But in terms of the damage to their health that this having to treat them in this way is doing?
So we as breast surgeons are very lucky to have very clear guidance from the Association of Breast Surgeons, which is the UK's authority on breast surgery, and they have guided us in terms of which patients to offer which treatment to, so to maximise our use of resource whilst minimising harm to women who are newly diagnosed with breast cancer. and we are operating as safely as possible. But there are still people whose operations will be delayed. So they'll be put on treatment for their breast cancer in the form of hormone tablets. So they shouldn't have any adverse outcomes from a breast cancer point of view. But whilst they're on hormone tablets, they will know that their breast cancer is still there and hasn't been treated with an operation. And that must be a source of incredible anxiety.
And it's clearly not the best possible care you would be giving in normal circumstances.
It's not the normal care that we would give, no.
How does that make you feel as a doctor?
It's very, very hard not being able to do. So we are still doing our best with the resources that we have, but it's very hard looking people in the eye and saying we are doing things slightly differently. And we're doing that in the emergency setting as well. We're treating a lot of conditions that we would normally do an operation for and cure there and then, or we would normally do a particular type of operation for, and we are no longer doing those operations, or we're doing a different operation, or we are treating people with antibiotics with appendicitis, for example, which in the UK is not our usual practice.
I mean, if we can look beyond maybe COVID several months down the road, I mean, what do you anticipate when you can go back to working in the way you worked before with all these people who have not been getting the treatment over these months that they should have normally been getting?
So I think we will never work the way we worked before, because I think we've learned some positive things from coronavirus that I'll talk about in a minute. But I think also we will just have such a backlog of patients requiring outpatient clinics and operations that we will have to change the way that we work forever to deal with that and to have the resources to deal with that.
I mean, is there going to be a kind of surge of people coming through? Because presumably you'll have the ones who haven't been treated properly now, and then the ones who would normally have been coming through, in their own time, as it were, maybe later in the year.
Absolutely, and I think one of the issues is that members of the public by and large are paying very careful attention to advice about not going out, and they don't want to overwhelm the medical facilities that we have. But I think I would urge any patient who is concerned about symptoms, be it bowel symptoms, be it breast symptoms, be it they're acutely unwell, that GPs are still open and providing an excellent service. We are still seeing patients in clinic if they have an urgent need to be seen in clinic, and we are still seeing patients as emergencies. And my main concern is that people aren't coming to see their doctors, whether it's as an emergency or for something that's not an emergency. And that's what worries me, is we have lots of people sitting at home wanting to do the right thing, not wanting to burden the health service, and that will do them harm. And we're already seeing that in emergency surgery. We're seeing patients who've had symptoms for a week, who in normal circumstances would have come to hospital on their first day of symptoms, and by the time they've got a week of symptoms, they're potentially very unwell and need more aggressive surgery or more aggressive treatment. And they're trying to sit at home and do the right thing.
Okay, we'll come back to what you said about the NHS changing the way it works maybe in the future, but I just want to ask you a bit more about you and the job you're doing now, as compared to what you would have done before. So before, you gave us an idea of your normal sort of day. What's your normal kind of shift now, if I can put it like that?
So a normal shift, so they're all emergency on-call shifts. I'm not doing any elective work at the moment. So they're all 13-hour shifts. And that will be assessing all of the surgical emergency patients who come to the hospital either via their GP or through accidental emergency, or who are in hospital for other reasons and then develop a surgical problem. I will be performing emergency surgery. So pre-coronavirus, that would be all sorts of things: appendectomies, taking people's gallbladders out, treating bowel perforations, bowel obstructions, abscesses, literally anything. Whereas now we are drastically reducing the number of operations we do as an emergency, because we are trying to reduce the number of general anaesthetics that we do, because we know that increases patients' risks of complications from coronavirus. But also I'm doing, therefore, night and weekend shifts as well. My husband's also a surgeon, and we've got 13-month-old twins. So we're trying, where possible, to work our shifts out so that only one of us is at work at a time, so that one of us can be at home looking after our girls. But it means that there's no normalcy, there's no normal work. It's all just emergency work, which is far more intense, which is far more stressful, and also just, very emotionally challenging because people are terrified. They're coming in very unwell. They don't want to be in hospital. They feel unsafe in hospital. They're worried about catching coronavirus, and they have none of their support network with them. They don't have family members with them. I've been telling patients that they need an emergency operation that's very high risk to treat, for example, a bowel cancer that's caused a bowel perforation or a bowel obstruction. And I'm having to have very difficult conversations with people on their own and through a mask, and they can't see the human behind that mask when they're terrified.
And have you had situations where people have basically not been able to see their loved ones, at the end when... Yes, and that has been, amongst all of us, something very, very hard to deal with. We are normally, I think, very good where possible at supporting patients and their families in the last stages of their lives. And there are lots of things that we would normally do to try to support patients and their families that we are unable to do. And I've had to inform family members via phone call or video phone that their family member is unwell and isn't going to survive. And I've had to be the person holding that person's hand with a glove and a mask on. And if it was me, I'd rather have my loved one holding my hand and not, a faceless member of the medical team. That's a huge extra strain on you, isn't it?
It's nothing in comparison to the strain that those patients and their families are going through. But it is very emotionally challenging at the moment. And I think that's something that potentially we haven't thought about as much. We've thought about the physical protection of our staff members in terms of PPE, but I think we're all just finding it very hard from an emotional and a mental health point of view.
I mean, just to go back to what your work. I mean, when you're on the emergency unit and dealing with people coming in, do you know whether they have COVID or not, or are you having to work on the basis that everybody who comes through the door might have it?
So our hospital offers a sort of broad triage service. So we ask patients if they've experienced any symptoms of coronavirus, and if they've had a temperature or they've had a cough or any other symptoms, then we would treat them as suspected and swab them and treat them as having coronavirus until proven otherwise. The problem in general surgery is that lots of the conditions that we treat with an operation cause people to have a temperature. So we can't tell if their temperature is from coronavirus or because they've got an infection in their tummy. We are also, any patient who's having a CT scan of their abdomen to help us plan what operation we might need to do is also getting a CT scan of their chest. And a CT scan of their chest gives us an immediate result as to whether or not we think they've got coronavirus, and is more sensitive than a lot of the swabs that we use. So if patients have a CT of their chest, we have a pretty good idea of whether or not they've got coronavirus.
I mean, have you ever been in a situation when you've performed some surgery or worked on a patient, maybe without the full PPE, and then suddenly someone said, "Oh, actually, that patient has tested positive"?
So any patient who goes to theatre in our hospital is treated with full PPE. So that's with an FFP3 mask, and we treat every single patient who's being anaesthetised as if they have coronavirus, because the risk is otherwise just unacceptable to staff members.
Okay. What about colleagues? Have you had colleagues who've gone sick?
Oh, absolutely. 2/3 of my tier on the rota has had coronavirus proven on a swab.
2/3?
Of our rota, yeah.
Wow. That sounds like a very high percentage.
Yes, it's a very high percentage. And we think that probably that was from staff to staff transmission, because we've been very careful in our interactions with patients. But when we're doing handover, for example, or when we are having a break in the coffee room after, during our lunch break, then we're all sitting there without wearing PPE amongst ourselves. And there's a lot of understanding that staff to staff transmission is probably one of the highest transmissions rates in hospital. You
must worry about catching it yourself.
Absolutely. And to be honest, I'm amazed that so far we don't seem to have done, either myself or my husband.
And as you say, you have 13-month-old twins at home.
Yes, and I would hate for them to get it. And I would feel incredibly guilty if I felt I'd brought it home. So my husband and I are being very careful. We have outfits that we only wear to work and so we get changed as soon as we go to work. We change our shoes, we alcohol gel everything, we place our phones in sandwich bags so that we don't touch our phones while we're at work. And then as soon as we come home, before we see the babies, we put our clothes in the washing machine and they get washed at 60 or 90 degrees. We have a shower, including washing our hair, and only after that do we get to see the babies.
I mean, you sound obviously extremely disciplined about it, and dare I say, quite matter of fact about it. It can't feel that matter of fact a lot of the time.
I think that's a really good point. I hadn't even thought about feeling matter of fact about it. I think the reality is that as healthcare workers, we are used to dealing with life or death and difficult decisions every day. And coronavirus has been an unprecedented challenge that I think none of us could have even predicted or expected. But we're used to, unfortunately, just getting on with things because that's what you have to do. There's no alternative, really.
But it's a bit different when it's your own family.
It's very different, and I certainly feel that my attitude to being a doctor and being a surgeon has changed dramatically since the arrival of my twins. And I feel very different as a parent and as a patient and as a relative. And I think it's given me far more empathy with my patients and colleagues, and it has definitely changed the way I work.
And can you give me any example, if I can put it like that, of how you feel it's maybe changed the way you work?
I've certainly found it much harder to look after paediatric patients. So one of our daughters was very unwell at the beginning of the year and spent a week in hospital, and unfortunately she's made a full recovery. But I now find it much harder dealing with younger patients who come in unwell, and I think I have huge empathy towards their parents. Not that I didn't before, but I really understand now how it feels to be a parent and watch your child being unwell and feeling like you have no control over that situation. And I think it's made me feel much more protective towards the paediatric patients that I operate on.
And you have to stand there oozing confidence, I guess, and when maybe inside you're feeling a little, oh goodness me, this is tough.
Oh yeah, absolutely. And I think that's something that we feel even during normal times, is that you want to be confident, you want your patients to trust you, but you also have to be human and recognize that we do all make mistakes. We do all suffer crises of confidence. We do all just do our best, really. And I think it's trying to show people that we just do our best. And sometimes that's not enough. But as long as we can go home and say, I did everything I could, then that's how you sleep at night.
I mean, do you worry about the fact that you have to go home after being in a situation where, as you say, 2/3 of the people on your rota have caught it, and then you're going home? I mean, you must worry about that.
I find it very hard, and I think that was my first and main concern, actually, when everything started, was to protect my family. And you do get worried when you go to work. You think, am I going to bring it home today? And that's very hard. And I think it's only luck, really, rather than anything else, that I haven't caught it and I haven't taken it home. And my husband and I talked about everything extensively before we started our emergency rotas, and said that if one of us were to have coronavirus, then we would isolate away from the family home.
Oh, well, that would be extremely difficult.
It would be really hard, but I think for us it would be the safest thing to do.
Okay, well, it's all good that it hasn't happened so far. Let's hope that obviously carries on. Fingers crossed.
Absolutely.
All around. I mean, it's obviously not just a matter of luck. As I said, you're obviously clearly very disciplined about the way you deal with it. I mean, do you feel you can see the kind of end of this particular crisis at the moment?
I think that's a really good question, and I think that's a very difficult question to answer. I don't think we're anywhere near the end. I think as we ease lockdown, we will have a second wave, we'll have a third wave, and I think unfortunately those waves will be a necessary evil until a vaccine is developed. And so I can't see for the next month, if not year, for us not being inundated with coronavirus.
Really? I mean, because there's a lot of, I think it's fair to say, in terms of the way things are trying to open up, and the government is obviously encouraging an opening up of business and normal society, that there is a sense that we're through the first wave, certainly, but it sounds as if you feel like, even if it's not like that.
So I think we're all terrified for the long-term recovery of the country, for the economical impact of coronavirus. I think the huge amount of money that's been spent on the NHS is going to have to be recovered somehow, because it's cost a huge amount already to society, and easing of lockdown will clearly be necessary at a point decided by the chief medical officer and the government, but there will by definition be a second wave and a third wave as each stage of the easing of lockdown occurs, because we don't have a vaccine yet.
And would you expect those waves to be similar to this one?
I hope not. I think we've done really well, and I think the NHS has done a fantastic job, and I think the general public have done an amazing job of flattening the curve, and I think it hasn't been potentially as catastrophic as we thought it would, but that doesn't mean it's been easy, and that doesn't mean that the second wave will be any easier.
You mentioned earlier that you thought the NHS would change the way it works as a result of this. Can you give me an idea of what you meant?
So I think there are some positives actually, in terms of if we've learnt what we need to do and what we don't need to do. So within our specialty and a lot of other specialties, we've been doing video consultations and telephone consultations, and we've realised that actually the traditional model of seeing patients physically in an outpatient clinic isn't always necessary, and that we can massively improve the way that we work and improve our efficiency by offering alternative ways of interacting with a doctor. I think it'll be really interesting. There are globally a huge number of research projects going on looking at how we've changed our practice in response to coronavirus. For example, will we be treating all appendicitis with antibiotics in the future? Because if it's working at the moment and patients aren't needing their appendixes taken out, well, could we save them an operation and treat their appendicitis with antibiotics, for example? We'll have tens of thousands of patients for whom this has been the case worldwide, and we'll be able to follow them up and see if it's a safe and an appropriate thing to do.
And what about if it's changed the way you feel about your profession and the choice you took?
I think it's made me really proud of the people that I work with, and really proud to do the job that I do and to do it to the best of my ability. I think the thing that I have found hardest of all, that has made me reflect on who I am as a doctor and the way I work as a doctor, has been having to wear a mask and gloves when I interact with patients. And I've had a couple of situations where patients have been very unwell and towards the end of their lives, where I've been relatively certain that they don't have coronavirus, and I've taken my PPE off because I've wanted them to see the person that I am, the human that I am, because that is so important to me, to be able to interact with my patients in that way.
I guess that would have brought a ticking off from the people who say you just broke the protocols.
No, I don't think it would have done, because to be honest, I think if they've had a CT test and it's negative, then the likelihood of them having coronavirus is virtually zero. So, right. No, I think we all have to show some compassion sometimes, don't we?
Yeah, well, I was thinking like a bureaucrat there. Okay.
I know you were, but I was refusing to be drawn on it.
Okay. Finally, I mean, obviously, the NHS, people like yourself, the job you've been doing, the public has become extremely aware of what you do, and obviously there has been the very public displays of support. Does that impact on you at all?
The public displays of support have just been absolutely overwhelming, and it is so lovely and so humbling to receive those displays of support. The reality is, as NHS workers, we're really lucky, and I know it probably doesn't seem like that, but we all still have our jobs. We're all still being paid. We are all very lucky to have been having a huge outpouring from the public of support in terms of meals and transport support and things like that. And actually, we're not the ones who need it in the nicest possible way. There are the really vulnerable members of society who have been so unfairly impacted by coronavirus, by not being able to work, by not being able to travel, by not being able to get outside. And it is those people that I feel particularly sorry for, who are the sort of unnoticed members of society who are really struggling at the moment.
Does the sort of Thursday night clap and the other expressions of support, does it make a difference to you when you're setting about your work?
It really does. It is so nice to be appreciated. And I think we all feel that whatever job we do, be it in healthcare or otherwise, people are very quick to criticise, people are very quick to complain, and you are much more likely to receive a complaint than a compliment, because it's just not within our nature to take the time to write to somebody to say thank you. And I really hope that if and when this is all over, that we'll all as a nation think about showing a bit more gratitude to people and taking the time to thank people, and perhaps thinking twice before we complain about something that doesn't matter.
Well, Zoe Barber, I certainly want to thank you for that. Thank you very much indeed, and wish you and your family all the very, very best.
Thank you very much. It's been a pleasure.
Zoe Barber, she really is a key worker. If you have any thoughts on this or any ideas for other editions, you can email me on andy.bell@itn.co.uk, and I'm on Twitter at andybell5news. Thank you for listening to this edition of How Did We Get Here, and there'll be another one along soon.